The clock on my old computer is broken. It says it's 12:14, so I know that that's wrong. So I always have to check my watch. At least it's broken in the wrong way. It gets me there on time rather than 10 minutes late. I'm Ted Johnson, pleased to welcome you to GM Insights today. We've got a treat for you. I get to see Dr. Hales present quite often, and so I know you're in for a special session today. Dr. Chad Hales is a physician scientist. He's a cognitive neurologist. He's an MD, PhD from Medical College of Georgia. He sees patients regularly who have cognitive impairment in clinic weekly at the Goizueta Alzheimer's Disease Research Center clinic at Emory University. He's dedicated to understanding the basic cellular mechanisms of neurodegenerative disorders like Alzheimer's disease and frontotemporal dementia. Dr. Hales has been personally touched by his grandfather, who had a neurodegenerative disorder, eventually succumbing to that disease. So I know that he's going to bring forward to us some cases today. I'm going to let Lori Beth go ahead and show us our disclosure slide, which I think is our first slide in the presentation. Maybe it's the last slide in the presentation, and I'll go ahead and turn it over to Dr. Hales. Oh, there we go. There's the disclosure statement. We'll go back to Dr. Hales' title slide. Turn it over to you, Chad. Thanks so much for joining. And thanks to everybody for joining in today. We're in for a great session. Thanks.
Perfect. Thanks, Ted. Is my volume okay?
Yes.
Excellent. Excellent.
You're great. Thanks.
Perfect. Thank you so much. So, well, thanks for having me today. Always fun when I get to chat with folks about different cases that we've seen. Of course, the goal will be to give you a little bit of a background on how we approach patients with cognitive symptoms, and hopefully by the end of this session, you'll get a little bit of a kind of solidifying how you approach these patients with the questions you might ask and some of the historical elements that you might understand and review, as well as different data elements that can be helpful when you're thinking about diagnosis for patients. So that's that second learning objective, is reviewing the brain imaging and getting comfortable with that. And then finally, I hope a take home that you'll have is to really understand the importance of the accurate diagnosis. And this is something that often comes up in discussions across different specialties as to, well, why is it really all that important to understand what that underlying, and the way I describe it to my patients is, what's making those brain cells not work like they're supposed to? What's making those brain cells sick? And that's what we're, hopefully going to get to show you today. Just briefly, as we approach patients with memory complaints in the outpatient setting, as a neurologist, the history is really important. And so after you chat with the patient and family for a few minutes and ask a few targeted questions, you start to build a story and a hypothesis of what you think that patient may have. And that's really true for anybody in the medical field when you're really trying to understand the underlying cause of whatever the patient's symptoms are. But it's especially true in patients that might have underlying cognitive complaints, because many times some of those symptoms that may give you clues about the underlying etiology may have occurred years before, and you have to really kind of dig into that, oftentimes more with the patient's family or their caregivers than with the patient themselves. Occasionally, especially early on in the course of the disease, patients may have really acute insight and be able to answer some of these questions. And so I just show some of the standard historical stuff here that we would typically be reviewing. And then, of course, supporting data is critical too. As you're thinking about the different symptoms that you're seeing, what are some other pieces of information that you can look for, either on examination, if you're thinking about, could this be a patient that has one of the Parkinson's-based syndromes, such as Lewy body dementia? Maybe they've got some slowing or some tremor, or maybe they've had some acting out dreams, or, are we seeing some clear patterns of atrophy on the imaging results that would provide us with clues of etiology? And then other supportive features, even neuropsychological testing can provide insights about which cognitive domains are impacted for that particular patient. And then you can decide, does it fit with what you see on the brain imaging or not? And then finally, trying to really delve down into some of the quantitative values, which is where the field is moving. And those are, different biomarkers. And of course, in our cognitive clinic, we often use spinal fluid testing to try to understand different changes going on, particularly related to Alzheimer's disease. But the field is catching up and with other neurodegenerative disorders as well, and trying to develop biomarkers. And of course, when we start thinking about more widespread use of biomarkers, plasma or blood often comes up. How is that going to be integrated into our clinical practice? And of course, that is certainly on the horizon for Alzheimer's disease sooner rather than later. And then, of course, for some other diseases as well. And then you can even take it a step further. And this is where it gets kind of interesting and exciting at the same time when you start thinking about genetics, right? Sometimes you may even be able to use some of the underlying genetic information. We're not quite there yet because it does require some of that expertise on the bioinformatics side to understand, what do the different variants mean. But I do envision a time as we move through the next couple of decades where that genetic information is also going to play into, well, how do we adjust medications and that type of thing for our patients. A brief comment on the diagnosis, right? Sometimes it's straightforward. So, if it walks like a duck, quacks like a duck, probably a duck type thing, right? If they're amnestic, if they're 82 and they have some hippocampal atrophy, then Alzheimer's disease may be there. Sometimes it's multifactorial. And so we're often left trying to decide how much does each diagnosis contribute to the patient's underlying symptoms. And this is not only true in the clinical setting. So when we're actually talking to the patient about the different things that may be impacting their cognition, whether it be mood or substance use, or maybe they've got some vascular risk factors, but even down to the pathological level, we know when we do neuropath studies that there's often a lot of overlap between the different pathologies when you start looking at the brain cells. Again, what's making the brain cells sick? Is it tau pathology, amyloid, TDP-43, which is another protein that may aggregate in the brain, cortical Lewy bodies? All those types of things can start to accumulate. But again, how much does each contribute? And then sometimes you find something that just totally upends your initial diagnostic thought process. And then it ends up becoming, that elephant in the room. So I've got 3 cases here. 2 of them are to highlight some of the different imaging findings that we see. And then the one at the end is probably one of the easiest, but probably one of the most important when we start thinking about future care for patients, particularly with disease-modifying therapies. So this first patient is a 50-year-old woman presented with some memory and word finding difficulty. And by memory, she was having a little bit of difficulty with conversations and appointments, some of that kind of classic amnestic type profile. We heard kind of a typical, I'll walk into a room and don't really know why, but as you recall, I said she's in her 50s. So, is that something that we should really be seeing a lot of at that age? She had been battling some major depression and had some different spells. So right off the bat, you can see this is not a very straightforward patient because these spells were described as these kind of non-epileptic spells that you might see in patients that almost borders on conversion disorder when you start thinking about subconscious events that are neurological events that happen. And of course, these non-epileptic spells or seizures are sometimes seen and often will coexist with prominent neuropsychiatric features. And the symptoms hadn't really progressed. And so this is kind of an important key as well. Not seeing that kind of more classic downward decline that you may have with an underlying neurodegenerative disorder. Overall, though, she was still quite independent and just having some very minor assistance with her finances. Of course, other key historical elements that we briefly alluded to, motor symptoms, really nothing that would suggest Parkinsonism. Sleep, she described as a little fragmented, but again, nothing to suggest abnormal REM sleep disorder. Mood, we've talked about some challenges there. No real psychotic symptoms to suggest psychotic depression, which occasionally does pop up in our clinical setting. And she'd had some previous workup, including different medications tried. And so, of course, this patient had been trying lots of different things from an antidepressant and neuropsychiatric perspective, and was also still in psychological counseling. Reviewing the standard stuff here, you can see that past medical history does have a lot of different things we've already mentioned, including some vascular risk factors. You can see our medications here, which again include a couple of different neuropsych-based medications, the clonazepam, as well as sertraline, as well as some of the antihypertensives there. Really nothing from a substance use perspective. And one of the things that was on my initial slide was different questionnaires that can be helpful as part of your initial diagnostic thought process. And, in this particular case, I'm showing you an anxiety scale, which is pretty high. I'm showing you a depression scale, which is also up there. And then this is a functional questionnaire, which just suggests maybe, like I said, some very mild assistance with some other things. Her neurological exam, not going to spend too much time on it, pretty normal. I have her MoCA here just to show you that she's doing pretty well, just a little bit of a borderline MoCA. That's a 24 out of 30, and some impaired attention and executive on other domains, which is not surprising, right? This is a lady who has some depression. She's got some of those frontal subcortical networks are likely impacted by that depression, perhaps even a little bit impacted by some of the medications. So not surprising to see some of these isolated deficits. She did have low B12 and was being supplemented by a physician. And we see this often, and it's hard to say, well, again, how much is that low B12 actually contributing to their cognitive dysfunction? And sometimes even if you just have the B12 in conjunction with the CBC, you can get a little bit of a feel by looking at some of the other correlates like MCV. Sometimes you may need to order some additional studies to understand how well the body is utilizing B12, but I would say it's pretty rare that you actually see even a lowish B12 starting to impact cognition, but it is important to look for it, and usually not in isolation if it's that severe. Usually you may see some sensory or other changes as well. Brain imaging, as I mentioned, so big key when you're reviewing cases, and I'm just showing you some T1 images here. You see a coronal up here, a sagittal over here, and an axial here. Always important to use your T1 images to review for atrophy, just because that gives you the best visualization. And I think you can appreciate that, at least here on this coronal view, the hippocampi, they actually look pretty good there. Sagittally, you're not seeing a whole lot of difference throughout. You could argue for some very mild biparietal atrophy, but I would not call this. I mean, this is very, very subtle. And so you're really trying to compare across the brain there. It looks pretty similar. And then on the axial, we're looking here at the ventricular system, which looks nice and narrow, what you might expect to see for someone in their 50s. When you go over to their FLAIR image, though, so this is the image that gives you a really nice look at those subcortical changes. You see a lot of stuff, right? You've got some things in the pons, you've got some stuff in the temporal lobe, you've got a whole lot as you get up into the subcortical white matter tracts. And so this is in that moderate to severe range with respect to microvascular ischemic changes. So starting to see something here. Now, the diagnosis, right? We've talked about some neuropsychiatric stuff. You've got some microvascular, but as we mentioned at the top, how can you really decide how much that's contributing? It certainly is a fair bit that's there. Could this be demyelinating? We haven't heard a lot about multiple sclerosis or, lots of different attacks of acute neurological illness. And even vasculitis, right? But she's not very sick, right? So this is a lady who's still doing quite well and probably less likely. But could it be something else? And this is where kind of the diagnostic piece of looking at imaging and trying to understand, does it give you a pattern, comes into play. And so what I'm showing you is down here on the bottom, image from an article that shows some temporal lobe changes, which we also saw in our patient. And you've also got some of this external capsule signal here too. And when you see this type of a signal pattern, it can actually suggest something called CADASIL, which is kind of an interesting type of syndrome where she checks some of the boxes. Okay, so this is one of those kind of rare syndromes that folks will end up having early stroke. They often have a fair bit of cognitive impairment, lots of psychiatric disturbances, and even sometimes seizure, although for this patient, we heard it was mainly non-epileptic, but certainly something to think about. And these patients can actually have an autosomal dominant mutation in the Notch3 gene. For this particular patient, we actually ended up not proceeding with the additional testing, genetic testing for this, because she didn't really have the recurrent stroke piece, and also just the cost of that test was somewhat prohibitive at this point in time. So we were left with controlling things that we know we need to control, and this is something that's important for our patients. Is oftentimes when you've got lots of things in the differential, going after you can often identify something that can be modified. And it's important to really try to optimize some of those things first, even if there's something else going on, like the vascular changes or like CADASIL or whatever else. We know that there's some opportunities to be gained with the neuropsychiatric management. So that's the big key here, is going after some of those things that we know are there, but also just kind of keeping your eye out for some of these more esoteric type etiologies. The second patient is an 80-year-old lady. Memory loss, language. She's a little bit, further advanced than our previous patient. Had a stroke, but had recovered very well from that stroke previously. Had been mildly progressive for years, but then one of the classic type of stories we get is that over the last 6 months, really had marked worsening of her overall cognitive decline and symptoms. And, often we try to say, well, was there some type of an event that the patient experienced that all of a sudden unmasked some underlying changes that may have been there? Her age certainly puts her at risk for an underlying neurodegenerative disorder. There was a mention here of a possible fall and a small subarachnoid hemorrhage. And, we'll talk a little bit about that in a couple minutes. Medication, she'd actually already been tried on some AD symptomatic therapies, including donepezil. No clear family history other than vascular stuff, a little bit of cancer. And from the questionnaire perspective, I show you another one here on the activities or independent activities and daily living combined scale, where 51 is normal, and she's down a bit, suggesting that she's needing some assistance. Mental status, she was again much more impaired than some of the previous patient. Attention, she was sometimes kind of fluctuating during the exam. One of the executive tasks I'll give is for patients to tell me the month of the year in reverse, and she can only give me one. And then her language was also pretty much non-fluent with some profound word finding pauses. Her general exam was relatively unremarkable, just a little bit of generalized mild weakness. As far as the neuropsychological testing, you can see she's down at a 14 as compared to our previous patient, and her lab studies were also within normal limits. Showing you a couple of scans here, which highlight a couple of findings. The flare images across the top, again, looks a little bit better than our previous patient, but, is showing a couple of changes. So there's this spot here, as well as here, which might suggest an old cortical infarct. Actually, I got a couple of white arrows here, which are showing a little bit of asymmetry between the right and the left mesial temporal lobe, suggesting some mild hippocampal or temporal changes, although the hippocampi are not terribly small for somebody of 82. And so, maybe there's a little bit of atrophy. You could certainly argue for some hippocampal atrophy or some parietal lobe atrophy here. You can notice that the gyri are a little bit more enlarged than what you see up here in the frontal lobe. So based on the imaging, maybe evidence for a prior stroke, which we knew about, as well as some atrophy that in the right clinical setting could support Alzheimer's. But this is the money shot, right? So this is looking at the gradient echo. And I wanted to highlight this sequence because I feel like it often gets overlooked. And I've seen this overlooked so many times in community-based scans that it's almost malpractice, to be honest. But it sometimes doesn't get, get reviewed, or it's subtle and gets overlooked. And in this particular case, it is not subtle, right? So this is the gradient echo or susceptibility weighted imaging, which shows you evidence of hemorrhages or any prior hemorrhages in the brain. I describe it to my patients as it's like a tattoo on your brain, because as you have blood products leaking into the brain, it leaves a little bit of iron deposition that's taken up by some local cells and macrophages, and that stuff is there pretty much forever, and until I don't know if it ever goes away. Some of it resolves, but you're left with these signatures. And as you can tell, this person has a lot of these cortical microhemorrhages. There's some superficial siderosis, which is this layering of the hemorrhage across the surface of the brain. And here's a zoomed in version of that for you. And anytime you see this in an older patient with suspected underlying AD, then it's almost certainly cerebral amyloid angiopathy, which is the same amyloid that deposits in the brains of folks who have AD. But in this particular case, it deposits in those blood vessel walls and makes them more leaky. And, for this particular patient, they had some leaky blood vessels. I mean, this has been going on for a while. And like I said, you often see this coexisting with Alzheimer's disease. And so even though we didn't do additional biomarker for testing for this patient, the level of impairment and the presence of CAA almost makes it a certainty that she has Alzheimer's disease as the primary etiology for her underlying symptoms, along with maybe some static impacts from the prior stroke that she had, and of course, risk moving forward of additional brain hemorrhage. Cerebral amyloid angiopathy can cause, as you see, multiple microbleeds. It can cause larger hemorrhages. And, you know, it's kind of interesting when thinking about the pathophysiology. Is this representing some type of way that amyloid is being cleared from the brain through vasculature, lymphatic systems? And, you know, for these patients, does this represent some type of altered amyloid clearance that suggests maybe they're not doing it as well as they should? So it is an interesting phenomenon. And I actually had a patient in my clinic just yesterday, had Alzheimer's disease, and the report mentioned nothing about microhemorrhages. The family had been told nothing about microhemorrhages, but on the MRI from 2019 that I reviewed, there were at least 15 to 20 microhemorrhages on the gradient echo scan that were very easily to see, and also very cortical based, which is where you typically see the cerebral amyloid angiopathy. And you might say, well, does that really make a difference? Well, when you start thinking about bleeding risk, many patients who are older and may have cerebral amyloid angiopathy may actually need to be on anticoagulants for some reason or another. And this is where the quandary kind of sets in. And we actually had a conversation just last week with our clinical provider group as to, well, what is considered safe number of microhemorrhages to have someone on a full level anticoagulation, say for stroke prevention and atrial fibrillation. There is a little bit of data out there that suggests if you have one microhemorrhage, then maybe your risk of having a larger hemorrhage on an anticoagulant is very similar to what if you had no microhemorrhages. Above that, though, the threshold is unknown. There's really not enough data to suggest. And the way I talk with patients and families about it is I look at how ominous this particular patient, very ominous, right? If you wanted to think about anticoagulation for this patient, you may want to think otherwise, because the risk for hemorrhage may be greater than the risk of, ischemic stroke and stroke prevention or that type of thing. But it is a risk-benefit discussion. No right answer, but certainly something that you want to make sure that patients and families are aware of so that they can keep track of that. Now, in the last couple of minutes here, I do have my final case. And this is a 50-year-old gentleman, very standard, straightforward, 1 to 2 years, progressive memory and word defining difficulty. The only thing not standard is the 50s part, right? Still working and doing quite well, maybe a little bit slower on some of the working tasks, but otherwise doing okay. Other IDLs, ADLs are normal, really no mood disturbances. When you start looking at his lifestyle, he already was on a Mediterranean diet, did lots of exercise, very healthy gentleman, like no other medical issues. His outside provider had actually put him on memantine. They had tried donepezil first because it's just starting with the acetylcholinesterase inhibitor, but he had a little bit of trouble with sleep, and so they switched him over to memantine. Again, there was a presumptive diagnosis of possible early onset Alzheimer's disease based on the clinical history. There was no clear family history of early onset dementia, although one thing that was missing is that his father had died a little bit on the young side. And so it was really incomplete family history. The grandparents, no clear findings of early onset dementia, so you didn't really have those two generations that you typically like to see. You can see MMSE looked pretty good. Maybe a little bit of mild changes in language, executive, and memory on full neuropsych, but otherwise, otherwise doing quite well. And here we have again, this gentleman had a borderline low B12 and was being treated. You can see on the scan here, I'm showing you a flare on the left, no significant subcortical vascular changes, looks okay. For 50s, you might argue that maybe these ventricles are a little bit larger than what you might expect, but when you look over on the T1, probably okay. Not a huge amount of change here in the hippocampus. Hippocampus looks pretty good. I will say there were some subtle findings though. So when you looked at the sagittal, I think you can appreciate that on the right side, these gyri and the sulci here look just a little bit wider than what they look like over on the left side of the brain. And also, although I couldn't really show you on that previous coronal image, there was also a little bit of anterior hippocampal atrophy that was slightly more on this right side than on the left side. Subtle, but present. So differential, is this age-related memory loss? I mean, he's actually got a couple of minor impairments on cog testing. Is it early onset AD, which is what an outsider provider thought? Could it be a variant of FTD? We've got some subtle hemispheric atrophy in the frontal lobe. Is it just neuropsych? Well, I've already told you he wasn't really depressed or anxious, so probably not. Could this be something esoteric, like an autoimmune encephalopathy? Well, he wasn't that sick, and the progression was over a year to 2 years, so probably less likely. I actually did spinal fluid testing on this gentleman, and it was completely consistent with Alzheimer's disease. Amyloid was low, total tau was up, and phospho-tau was up. And of course, the heritability piece, unknown at this point, and this is something that we're pursuing, is this kind of the genetics piece to it. But so the reason I bring this case up is these patients pop up all the time, and you have to decide, is there a subtle finding on the imaging or something in the history or neuropsych testing that makes you want to go for that additional biomarker studies? And is that going to change your management? In this particular case, he's still very mildly impaired. And this is the type of patient who might actually might benefit from clinical trials or disease-modifying therapies as they become available. Of course, if that happens in the next year or two, and there are several medications currently in the FDA pipeline that may hit and hopefully have better efficacy than the aducanumab blow across the bow, then this is going to be commonplace, trying to find these patients coming in, and then us trying to decide, is this underlying AD, and triaging to the appropriate therapy. So I highlight this case because it seems straightforward, but it's something that until you think about it and start asking the right questions, in getting to that biomarker evidence, you don't have that accurate diagnosis. So hopefully I gave you a little bit of insight into a couple of things involved with some of the FLAIR images, and the first case with an interesting concept of CADASIL, the importance of reviewing your brain imaging, particularly your gradient echo or susceptibility weighted imaging to look for hemorrhages. And then finally, the importance of that accurate diagnosis so that we can take the best care of our patients as therapies become available. So I will stop there and see if there are any a couple of questions for the last couple minutes here.
Hey, thanks, Dr. Hales. We really appreciate it. That was fascinating. And I've invited folks to put questions in the chat, but I can also see whether or not they have a little tiny cartoon hand that they put up, and we'll call on folks that way. Wanted to just ask the first question, if I could, and that is, how soon do you think that blood and plasma markers will be available to replace CSF markers? And how often would you be recommending that we check these markers once they're available?
Oh, wow. A loaded question. I wish I knew for the blood part. I would say, I've heard as little as 1 to 2 years. There's already one that's out there. You've probably heard of the Precivity's test, which is available. Is it sufficient for placing on disease modifying therapies? Probably not yet. And I think that's probably the biggest issue is getting the field comfortable with using those markers as the marker for the therapeutic piece, because initially there may just be a screen that helps us identify folks who may need the additional biomarker testing to make, us and other physicians feel comfortable with putting you on a medication that may have some side effects. But I think the field will eventually transition, right? As they become more comfortable with it, just like with CSF, right? That's what we feel has really good clinical pathological correlation. And I think we will eventually get there with the blood-based biomarker testing. It does highlight a challenge though, because when it becomes more widespread, then what do you do with all of those results in those people? And I think that's where GMN is hopefully going to come into play. We certainly don't have all the logistics of this piece worked out yet, but having the infrastructure in place first for the diagnostics is critical. And then step 2 is, well, how do we translate that into the appropriate therapies and getting folks on those therapies?
Thanks so much for that comment. I really appreciated your other remark earlier about treat what you can treat, and when you find 5 or 6 different things. And so I think that's a really important take-home message. You talked about the history being so important. What is the piece of history that you can recall from all your cases that you worked on that has changed what you thought of immediately? Some piece of history that you go, gosh, now that I know that.
Yeah, I don't know if it's the piece of history, but I think it's actually looking at the age and then knowing what you may be looking for in that age group, right? So if I know I have a patient coming in their late 70s or early 80s, I'm already making my differential diagnosis. Alzheimer's is at the top, vascular is probably number 2, and then it kind of goes down from there. And so I use that to help kind of guide my questioning to kind of pinpoint, are you repetitive in conversation? I ask about language to get down to the temporal lobe or that dominant hemisphere. You'll ask about some of the executive function-based tasks, calculations, dealing with technology. That's usually a pretty big one. Can you use a TV remote? Are they having trouble with their phone? But just using that kind of age to really help you hone where you want to ask those questions, but also being cautious, because I just showed you an example of a early 50s gentleman who looked just like a patient who may be 81 based on their presenting symptoms. So always be willing to question the diagnosis. And I think that was one thing. I had a patient last week that presented to me with one diagnosis, but after I reviewed the extensive amount of workup and data, they hadn't had a couple pieces of information that I thought were critical to capture. And it really set this patient and family for a little bit of a loop, because they were working under the premise that it was this. And now I'm telling them that I really feel like we need to look at this other piece of data. So always be willing to question that.
Thanks so much, Dr. Hales. Really appreciate everybody joining us today. Appreciate the reception that we had. And then Dr. Kulresh, late question. What are the best tools for cognitive screening for patients who don't speak English or for whom English is their second language?
Yeah, good question. So the MOCA actually has several different translations that are available. It does usually require someone who speaks that language to use that. You do highlight a challenge. I know, at least from a Spanish speaking perspective, there are a couple of nice neuropsychologists around town who do help with that type of thing. As far as other folks, though, it gets tricky. And oftentimes we rely on interpreters to do some of the English versions, but even there are some cultural differences and things that may impact the way that neuropsychological testing, that test was actually developed. So you just have to keep all that within a grain of salt, and hopefully using some of the other type of data that you have based on activities of daily living and other historical elements to help you really hone in on what that diagnosis may be.
Great. Thanks so much. Hey, I hope you'll join us next month. We'll have more fun together, and I'm going to turn it over to Lori Beth to send us home. So thanks again, Dr. Hales. Really appreciate it.
Thank you, everybody, for joining, especially Dr. Hales for presenting today. Please take the time to fill out our evaluation survey to receive the CME credits. And we look forward to seeing you all next month on September the 21st. We'll actually have a presentation on cognitive assessment interpretation. So we look forward to seeing you all. Thank you.